Hi everyone, I'm Ivor Griffiths. I'm a consultant upper GI surgeon from the Queen Elizabeth Hospital in Birmingham in the UK. I'm extremely grateful for the organisers of the Columbian Association of Surgeons to invite me today to talk to you about an update on gastro-esophageal junctional cancer. I'm going to give you some background. We'll talk a bit about the classification of GOJ cancers. We'll talk a bit about staging investigations, some about the oncology trials. We'll talk a bit about surgical strategy, and then end on complications from surgery, particularly anastomotic leaks and when not to use esophageal stents. So there's been vast changes in the epidemiology of upper GI tract cancer in the UK in the last 50 years. We've seen reduced rates of squamous cell carcinoma of the esophagus. We've also seen corresponding reduced rates of distal gastric cancer. And pretty much 75% of our cancers are situated around the gastro-esophageal junction. We think this is due to lifestyle changes in rates of poor eating habits, increase in obesity, increase in reflux disease, associated with alcohol and smoking rates have led to an increase in Barrett's esophagus, which have increased rates of cancer around the gastro-esophageal junction, which are primarily adenocarcinomas. Sievert described his classification for junctional adenocarcinomas in 1998, and this was published in the British Journal of Surgery. Briefly, tumours were divided into type 1, which are lower esophageal tumours, type 2, which are focused on the gastro-esophageal junction, and type 3s are subcardial and invades the junction from below. There can be an overlap, and this classification system isn't completely reliable, but forms a basis for comparing research and, to some extent, helping you decide which operation to perform. But before we do that, we need to accurately stage this cancer, and it starts off with endoscopy. We need a high quality endoscopy report detailing the proximal and distal extent of the tumour. We want to know about Barrett's esophagus. We want to know about the state of the stomach and duodenum, as these are going to be used in the reconstructive efforts. After the diagnosis, we'll perform a CT scan of the abdomen, thorax and pelvis, often with a water load to look for any metastatic disease. If none's found, we'll do a PET scan in pretty much every patient, as this is known to pick up occult metastases in about 15 to 20% of our patient group. It'll often show second primaries in the colon and other areas, which will require further workup as well. If the PET scan's clear, we'll often perform staging laparoscopy, particularly if the bulk of the tumour is in the stomach, as this is good at assessing resectability, and it also allows us to assess for metastatic disease in the peritoneum and omentum. If none's found, we perform routine cytology, as this is important for patient prognosis. As the laparoscopy is carried out by an operating upper GI surgeon under a general anaesthetic, it also gives us opportunity to repeat the endoscopy and assess for margins as well. We use endoscopic ultrasound for several reasons, but the role is decreasing. We use it for assessing proximal nodal disease in the upper mediastinum, as this will often rule out patients for curative resection. We also use it to assess for suspicions for T4 disease to irresectable structures, such as the aorta. And we also use it to more accurately define gastro-esophageal junctional tumours where it's unclear what operation might be required, whether it's an esophagectomy or a gastrectomy, and this will look for submucosal disease, which might influence this. After we've done that, we need to decide whether the patient should have neoadjuvant chemotherapy or not. 80% of our patients get neoadjuvant therapy, and for the most part, these are patients with more than T2 disease or any evidence of nodal metastases. Very occasionally, we have patients who are borderline fitness, and for these patients, we may offer them surgery alone if we don't think they'll be fit enough for neoadjuvant chemotherapy and surgery. But they still have to have resectable disease, and often this is a difficult conversation. Next, we decide whether they're fit for surgery, and we can do this by assessing with lung function. Lots of our patients smoke, and therefore it's important they have a decent FEV1 to make sure they're fit enough for thoracotomy. Often our patients have comorbidities in form of angina and heart disease, in which case they will require echo assessment as well. But probably more importantly, we rely on functional assessment, and our physiotherapists routinely shuttle walk our patients and do a 6-minute walk test to see how fit they are. If there's any doubt, we perform formal CPEX testing to calculate their anaerobic threshold. We have a whole program of prehabilitation for patients undergoing surgery, where they meet our physiotherapist, they meet our dietitian and our specialist nurses, and they get on a informal exercise program to try and improve outcomes. As I said, about 80% of our gastro-esophageal junctional tumor patients will get neoadjuvant chemotherapy. The evidence base for this has evolved over the years, and these are the previous published trials. Some we're still recruiting to, including Neoscope and Neoaegis trial. But the landmark trial in this arena, published in the last few years, is the FLOT trial. And this is the FLOT4 study, which was published in the Lancet last year. The inclusion criteria for this was gastric or gastro-esophageal junctional adenocarcinomas. They had to be medically fit and technically operable, and they had any stage from T1 to T4. And the patients were stratified by fitness, location, age, and nodal status, and 716 patients were randomized to either FLOT, 4 cycles before the resection and 4 cycles afterwards, or ECF, ECX, 3 cycles, then resection, and then the similar regime after surgery. The survival rates were impressive. The median overall survival in the FLOT arm was 50 months compared to 35 months in the ECF, ECX arm, which is a landmark study, and therefore we've adopted FLOT in our centre. Surgery is really based on the CVERT classification. Type 1 tumours will routinely get an esophagectomy. Type 3 tumours will get an extended total gastrectomy. Type 2 tumours is where the controversy arises, as they could be adequately treated by esophagectomy or an extended total gastrectomy. And factors which may influence this include the patient's fitness. If they're not particularly fit for thoracotomy, we'll do transhiatal extended total gastrectomy. If they have lots of Barrett's going up the esophagus, this is best treated with an esophagectomy. If they have nodal disease in the chest, this is best treated with esophagectomy. And if they have lots of gastric involvement, it's probably best they have an extended total gastrectomy, provided proximal clearance can be achieved. The controversy surrounding type 2 tumours is going to be addressed in the Cardia trial, which is a Dutch trial comparing transthoracic esophagectomy and extended total gastrectomy in type 2 tumours. And the protocol's just been published, and we'll be looking forward to seeing the results of this in the coming years. Clearly, the nodal stations resected in each operation is vastly different, and we need to decide on the basis of this what nodes to resect. And this is where we rely on the PET scan and the EUS. to see which is better. And the Cardia trial is looking at just this aspect and also long-term survival. But by and large, our standard operation is a two-stage esophagectomy. There's 7 surgeons operating in my hospital, and we mainly do a lap abdomen with an open chest. Some of us do a full minimally invasive operation, and if there's any difficulties or any issues with the resectability, or the patient's had previous abdominal surgery to the upper GI tract, we may perform the operation as a full open procedure. If anybody's interested, we produced a video a few years ago now giving tips and tricks for two-stage minimal invasive esophagectomy, and this is freely available on the above link for you to look online and gain some information on that. Every now and again, we have a very bulky type 2 tumour with extensive crural or diaphragmatic involvement. And for these tumours, it's probably best to resect them through an old style left thoracoabdominal esophagectomy, as this opens both body cavities at once. And its main advantage is that you have multiple anastomotic options available to you. You can perform a standard esophago-gastric anastomosis, or if there's lots of gastric involvement, you can do a long rule loop up to the left chest. And occasionally, if you position the patient expertly, you can also gain access to the neck to do a neck anastomosis if required. I'd like to move on to talk about complications, which are very common in this operation as it's performed in elderly patients with advanced cancer, having chemotherapy, and also having significant comorbidities. The key in this arena is failure to rescue, and there's lots of publications in recent years looking at this issue, and failure to rescue is dying of a complication after surgery. Not all complications are salvageable. However, in units with good backup of ICU, interventional radiology, surgeons on 24-hour on-call rotas with radiologists available in the middle of the night to scan these patients, complications can be treated and better outcomes can be achieved with earlier identification of these problems. And this is a quote from Ivor Lewis, who first described the two-stage esophagectomy. He said that the esophagus was a difficult surgical field for 3 reasons: its inaccessibility, its lack of a serous coat, and its enclosure in structures where infection is particularly dangerous. All these remain true today. He also described the anastomosis as like suturing the unsuturable, but I don't recognize that in current times. ESO data, led by Lowe, published a series of nearly 3,000 esophagectomies from 21 high-volume centres in 14 countries, and they showed that complications were exceedingly common even in these high-volume units. Anastomotic leak rates were 11.5%, conjugate necrosis was 1.3%, and pneumonia rates still of 15%, and they still had 30-day and 90-day mortalities of 2.4 and 4.5% respectively. One of my major interests is anastomotic leaks. And the reason for this is they significantly increase morbidity and mortality from this operation. They adversely affect patients' quality of life due to the stay in hospital and the subsequent strictures. They're also very expensive to the health service, mainly due to ICU stay, but also due to the techniques and treatments required for the leaks. And sadly, research shows that anastomotic leaks lead to early disease recurrence and poor survival. And they also affect surgeons, and this is increasingly recognised to lead to burnout and stress among surgeons doing these operations. The ESO data and the ECCG group have kindly defined an anastomotic leak, and this is now defined as a GI defect involving the esophagus, anastomosis, staple line, or conjugate, irrespective of its presentation or method of identification. Type 1 leaks are where it's a small defect, which is usually treated with no change or just treated medically with antibiotics or with dietary modification. Type 2 leaks is a larger leak requiring interventional treatment but not surgery. And this could be a radiological drain, a stent, or bedside opening of the wound or packing of the neck incision. Type 3 leaks are where this requires a reoperation, often a rethoracotomy to treat. So what is the best management option for an esophageal leak? Well, sadly there isn't, and management options need to be tailored to the size of the leak, the state of the conjugate, and how fit the patient is, and whether you have control of the leak or not. So all of these options are entirely reasonable, depending on various factors, and I was going to go through some of them with you today. So this is a patient that's had a 3-stage esophagectomy. You can see the clips in the neck. They've had a routine contrast study showing an anastomotic leak. In this patient, the neck was nice and clean with no sign of infection, and therefore the patient was treated conservatively as they were very well, just with antibiotics, remaining nil by mouth, and using the feeding jejunostomy tube. And within a few weeks, this healed, and the subsequent barium swallow shows an outpatient scan showing the leak is fully healed. If the neck wound was red or pus was coming from the neck, it'd be important to open that wound to allow the leak to heal that way. The only issue with that is you need to dress the wound very carefully, and leaks in the neck do tend to stricture. So you need to monitor the patient quite closely for stricturing afterwards. This is a similar leak in a patient who had a 2-stage esophagectomy, and this is a very tiny radiological leak. The patient's extremely well. They have no symptoms, no temperature, no tachycardia. The bloods are completely normal. And in this case, we just treated the leak again conservatively, and as it was very minor, it just healed up of its own accord, and the patient suffered no disadvantage from this leak. This is a more worrying leak, however, when you come and do your postoperative ward round. The chest drain has bile in it, and this is an indication there's a more significant leak going on. This was a case after a 2-stage esophagectomy, where in fact the drain managed to erode its way through the anastomosis, and you can see that at endoscopy. Often in leaks, we assess with endoscopy to see how well perfused the conjugate is and look for conjugate necrosis. In this case, the drain was simply removed an inch to allow the small leak at the anastomosis to heal. And luckily that was treated very successfully. Leaks can be more extensive, and this is a patient of mine who suffered an MI after surgery and required treatment on the ICU for heart failure, and developed an ischemic leak at the anastomosis. And you can see there was an element of conjugate necrosis, and in fact an area of the stomach died. There's a large leak at contrast swallow with pooling of the contrast in the lower pleural space. For this leak, we asked for the radiologist to insert a guided drain right up to the anastomosis. And then we performed an esophageal stent to cover the anastomosis. And with this treatment, with IV antibiotics, antifungals, a drain and a stent, this leak, despite it being very large, healed very successfully. And this is the image after 8 weeks where the stent was removed and the leak had fully healed. And increasingly, our team have been using stents for these types of leaks. And there's a few tips and tricks for this for you to be aware of. We always make sure we use a fully covered removable stent. Partially covered stents get embedded and are very difficult to remove, and this is a catastrophe. Once we deploy the stent under X-ray control, we place a nasogastric tube through the stent to drain the gastric conjugate. In the postoperative period, we watch out for migration, and we check the stent position with serial chest X-rays every few days. The stent in general should be removed and replaced within 2 to 4 weeks. And that's to ensure that the stent doesn't get embedded, and we reassess the leak endoscopically. We also need to realize that the stents aren't useful in isolation. If there's any pleural or mediastinal collections, these need to be drained with radiological or surgical drainage. We don't use stents if there's any hint of gastric conjugate necrosis or extensive ischemia, and stents work poorly when the gastric staple line is the problem, as they don't expand against the conjugate and they leak around it. We also don't completely rely on the stent. We keep the patient nil by mouth. We give them antibiotics and antifungals. We treat them on the HD or ICU, and we remove the stents early to avoid erosions or embedding. We're very liberal with assessing the anastomosis and the conjugate with endoscopy. And this is to look for signs of conjugate necrosis. As you can see here, there's a large part of the stomach near the anastomosis which is dead. And this is a different treatment. It often requires surgery to resect that bit of stomach, particularly when the patient is extremely unwell. If they're well, it may just be mucosal ischemia, in which case you can just monitor them and see what happens, but they have to be monitored strictly on an ICU and given antibiotics, antifungals, and supportive care. If you're interested in looking up about that complication in more detail, we wrote a review last year, published in the World Journal of Gastrointestinal Surgery, and that's free to download. And as I said, if you do have a severe conjugate necrosis, the conjugate will need to be resected and an esophagostomy formed where the proximal esophagus is brought out into the neck, or ideally into the lower chest wall, where it's easier to manage with stoma appliances. And the idea there is that you recover them from a life-threatening situation, and then once they're out of hospital, make plans to reassess them and to see if they're suitable for colonic conjugate in at least 6 months' time to allow them to recover from the insult of being in ICU for several weeks, if not a month. We look after these patients very well after surgery, and we've got in the Queen Elizabeth Hospital, we developed several ERAS programs for all our upper GI cancer patients, and that involves working with the physios, the dietitians, our specialist nurses, and it gives some hints and tips for the junior trainees who are looking after these patients. If anybody would like a copy, you can email me and I'll happily provide them to you. And I'd just like to thank you for inviting me again. It's a pleasure to give this talk. I'm currently leading the esophagogastric anastomosis audit, so do follow us on Twitter. And if you have any questions about this talk, please feel free to email me. Thanks again. Thank you.